So we've been having conversations with our friends from KEMRI-Wellcome Trust research program, and today we want to talk about universal health coverage, right? Because everything that we keep talking about, research in health and all, there's also the other element of research in health, which talks about how best to actually deploy your health systems. Now, we have been having a conversation about universal health coverage. It was one of the big four agenda for the Ruto second term. It's one of the big five agenda for the William Ruto Kenya Kwanza administration, universal health coverage. And they've said, both two administrations, that the National Hospital then Insurance Fund, which is now the National Health Insurance Fund, is the vehicle to be used to deploy UHC. Now, we want to ask ourselves, so what does that mean? How do we finance our health systems, and how do we actually make them work so that universal health coverage actually works? Is NHIF the most practical way of realizing this? We are joined by Professor Edwine Barasa. Professor Barasa is the Deputy Director at the KEMRI-Wellcome Trust Research Program. Good morning, bro.
Good morning, Eric.
Karibu sana to Kenya's biggest conversation.
Asante, thanks for having me here.
Mm-hmm. You're Taylor and City's Taylor.
Same what's up.
Same what's up. Walisomea same school ile. Maybe your Taylor alisomeshwa na Taylor wa City.
One of those, huh?
One of those. Interesting to have a conversation. Excited to have a conversation with you. Let City welcome you with today's proverb. It is one of those cryptic ones. It only requires a professor to actually decipher.
I chose this proverb because I couldn't understand it.
Because you knew Edwin is coming.
I knew Edwin was coming. And I figured this man can unravel this one. Do not dispose the monkey's tail before it's dead.
Do not dispose the monkey's tail before it's dead.
Okay.
Hiya, Professor Barasa. We have tried. Our books zimeishia hapo. Now, please.
Do not dispose a monkey's tail before it's dead. I think the proverb, if I were to interpret it, essentially means that we shouldn't be too quick to dismiss anything. Any initiative, any project, before we consider if there are alternatives or options to turn things around. So when things are not working very well, we have two options. One, we can decide to cancel the initiative altogether, or two, we can decide to think about how do we turn things around. So before the monkey dies, don't throw its tail away. That's how I'd interpret it. But happy to hear from you whether that's...
The explanation makes a great deal of sense.
You'll not be happy to hear from us, Prof. Let's just say we are happy to hear from you. Does it finally...
So I hope that's close to, what the meaning is.
Does it start to make sense?
Yeah. So I'm from where I was at 6 o'clock to where I am now.
You have moved a great deal.
The caboose has moved.
A great deal.
Let's see what happens
in the next one.
Yes.
It actually does make sense, the version that Prof is saying. Before you say it's over, think. Is it really the way it should end?
Yeah.
Don't be too hasty about your decision.
Exactly. So that's how I'd look at it. Think about options to turn things around.
Great.
Yeah. Before you, give up on something altogether. Yeah.
Voila.
Good one. Now, let's talk about health financing. First of all, let's just understand the terminology.
Yeah.
What does that mean?
Great.
Financing health.
So great. We know that whatever it is that a country sets out to do, it requires resources. So when you think about any sector within the system, within a country, whether it's education, whether it's agriculture, health, and so on, you have to think about where will the resources come from? How will you deploy those resources? And how do you use those resources within a sector? So when we talk about health financing, what you're talking about is how do we resource the health system? Where do we look for funds? How much do we need? How do we spend it? And what do we spend it on? and what implications does it have to health system goals. So a health system has, you can list very many goals, but really what we want is to improve the health of the population, and we want to do it efficiently, and we also want to do it equitably.
Okay.
Yeah.
Makes sense so far. So it's about getting the money.
It's not just about getting the money, right? And this is the important thing. It's about, one, getting the money. Okay. First of all, figuring out how much money do you need. Okay. Then two, getting the money. And second, and more importantly, how do you spend that money to achieve your goals? Because you can have, all the money in the world, but still not achieve the goals that you want to achieve. So I'll give an example. When you think about the way health systems across the world are financed, the United States is the most financed health system, and yet it has, the level of financing is not at par with the health outcomes that we have in the country. So what that tells you is that it's not just about the money. You can mobilize a lot of resources, but spend it in a way that doesn't make you achieve your goals. So in a sense, spend it in an inefficient way, so you have a lot of wasting, or spend it in an inequitable way, so you end up benefiting the well-off in society as opposed to the people who actually need it. So that's really what we need to be thinking about, moving away from just we need the money to also think about how do we spend the money.
Spend the money.
Yes. So health financing concerns itself with all of that. Where do we get the money? How do we structure that money? And how do we spend it within the health sector in a way that helps us to improve the population of the country, people's, or rather the health of the population of the country.
Okay.
Yeah.
Then the other bit, universal health coverage.
Yes.
Okay, so we've talked about health.
Yes.
Then there's the universal and the coverage bit.
Yes.
Explain those.
So universal health coverage. So what do we want, again, what do we want from our health sector, or what do we want from the health system? We want our health sector or our health system to help us with one key thing, which is to improve the health of the population. So that's what we want. Now, how do we achieve it? There are many ways to achieve it. One, we need to figure out, so the key things is we need to figure out what are the healthcare needs of the population. Okay? So what are the healthcare needs of the population? And this is not just individual healthcare needs. We also have, sort of population or public health needs. So beyond the individual. So individuals, but beyond the individuals. What is a population healthcare need? So that's one. Second, we need to think about how do we meet those needs. So we need to provide health services to the population. Now, the ideal situation, okay, is that everyone within a country, okay, so when you think about a country like Kenya, everyone within a country has their healthcare needs met. Their vital or essential healthcare needs met. So that's the ideal situation. But we know that it costs money or resources to achieve that. So we also have to think about how do we get these healthcare needs sorted out. Okay? So what we want is a situation where as people are having their healthcare needs sorted out, they don't get into financial problems. So those are the two things. So that's what universal health coverage is about. It's about ensuring that everyone in a population, everyone in a country has access to the healthcare needs or services that meet their healthcare needs. Without getting into financial difficulties. Now, what do we mean by financial difficulties? We mean that when you have to attend to your healthcare need, you shouldn't have to give up other basic needs. So, for instance, you shouldn't have to sell an asset so that you can be able to meet your healthcare needs, so you can be able to access healthcare. You shouldn't have to have your child forego education because you have to attend to a healthcare need. You shouldn't have to get into debt because you're accessing health services and so on. So healthcare services need to be affordable. They shouldn't get you into financial problems. So two issues. One, access services. Make sure they're of good quality, because again, you can access services that are, harmful or not very useful, right? And then second, that process should not get you into financial challenges, which means we have to think about services and we have to think about financing. So when you put those two together to achieve that, then we say you've achieved universal health coverage.
Okay. So In Kenya,
Yes.
how can this happen? There have been many conversations. People have suggested this, that, the other thing. I'm almost sure there's a paper sitting somewhere that somebody has put together very well in terms of how this ought to play out.
Yes.
But if you look at the practicality of matters,
Yes.
the two things that you've said, a recipe for the completion or the successful achievement
Yeah.
of UHC, the services, and the affordability of it.
Yeah.
Do we have a marriage of the two in the country at the moment?
So I would say it's a work in progress. That's one. And second, there's a lot of thinking that needs to be done. So the question you've asked is quite broad, right? And it has several layers. But at the very top, again, going back to services and financing. On the services bit, as a country, the work that needs to go into is to figure out what are the healthcare needs of the population. Okay? Because different populations have different healthcare needs. So in a country like Kenya, most African countries, infectious diseases have been a problem for a very long time. Which is quite different from countries in the north, for instance, in the global north, where non-communicable diseases, so your diabetes, hypertension, and so on, have been the biggest issue. So if you are to map out healthcare needs for Kenya, they'll be slightly different from healthcare needs for a country like the UK, for instance. But then over time, what we are seeing is that the non-communicable diseases, your diabetes and hypertension, are getting to be at par. But we still have your infectious diseases. So what I'm trying to say is that the healthcare needs of populations are unique. Okay?
Yeah.
And so what you need to do, the first step is to figure out what are those healthcare needs. So map them out. Okay? And then second, map out what services do you need to provide or meet those needs in the population. So that's on the one hand. Okay? Now, when you do that, what you're going to realize, which is not a problem that is unique to the health sector. It's the age-old economic problem, which is that needs will be way more than the resources that are available. Okay? Which means you have to prioritize. You have to think about, we have 1,000 needs, but the resources that we have are less than that. So can we figure out, what services do we, or rather, how do we prioritize to meet these services in a way that fits within our resource envelope? And there's a process to do that. And you have to think about what are you trying to achieve to get there. So you have to select those services that give you the greatest bang for the money. Because you can't meet everything now. It's a process. Okay? So figure out the needs, prioritize them. Now, once you do that, then figure out what resources are required to sort that out. Then start thinking about now your financing. How do we structure our financing system to meet those needs?
Okay.
And that is about, number one, what are the sources of funds? How do we mobilize resources? Then second, how do we bring them together? So that everyone is covered. Remember, it's universal health coverage. So how do you make sure we bring everyone under this roof when you mobilize resources? And third, how do we actually deploy those funds? How do we pay for these services? How do we purchase them? How do we make sure that we link the services to the people and so on? So it's really layered. And what I've done is to give the sort of, because you've asked, how do you achieve universal health coverage? You have to figure those two. But we need to get into, so for each of those,
you have to go granular.
This is what you need to do for each.
Exactly.
A lot of pressure, in my opinion, has been put on the contribution.
The cost element.
Yes.
Without necessarily looking at these other elements that you talked about.
Yeah.
So look, it seemed like a very cut and dry formula. You pay your 500 shillings per month.
Yeah.
UHC is achieved.
Yeah.
Without looking at these other things that need to happen. Should it be, though, and it could be rudimentary thinking, but should it be that if you had everybody in the country contributing what they were on a monthly basis, for example, then the resource element essentially would be sorted out, because you should be able, 40 million people giving you 500 odd shillings per month, you would have the resources that you needed. And then the application of strategy, then when you map out, like we know, for example, the northern parts of the country, this is the health, burden.
Yeah.
Or this is the disease burden kind of thing. The strategy, then you already have people who are working on things like that.
Yeah.
Would it then be easy? So the pressure that has come on that money per month looks like the biggest part of the puzzle to figure out.
Yeah. So there are several issues there. One is the 500 shillings, and that sort of. So you're making the assumption that we are moving towards UHC using the NHIF because it is the NHIF that
we were told
asks people to contribute 500 shillings.
Yes.
Right. And before we get to the 500 shillings, what we need to think about is, number one, first of all, how much resources do we need? Okay, who said that 500 shillings is the level of resources that we need, to be able to meet our, to meet our healthcare needs? We haven't asked that question. We need to ask that. Who said that it's 500? Once we figure out how much we actually need, we need to think about what is the optimal way of collecting those resources. How do we collect resources? Right? Because that's an important function for health financing. And it's important because there are feasible and infeasible ways of doing that. Okay? Now, the way we are currently collecting resources through the NHIF is through contributions, like you mentioned, contributions from individuals. And it is quite clear, from the experience that the NHIF has had in Kenya since, NHIF has been around since 1966, right? So we have a long history, a long experience. It's quite clear from Kenya's experience and from the experience across most low and middle income countries that a strategy to collect health revenues through contributions, asking people to pay every month, is not a feasible strategy. Okay? So before we even talk about the 500, we have to talk about how we're collecting it. We are collecting it by asking people every month to pay the 500 shillings. Okay? And the evidence is quite clear, and the experience from Kenya is quite clear that it is not feasible to ask people every month to make contributions.
Why is it not feasible?
Why is that the case? That is the case because when you think about how to collect revenues, you have to think about your sort of social demographic structure as a country and how it lends itself to the way you mobilize resources. Okay, in Kenya, like in a number of low and middle income countries, you have a very high level of informality. Yeah. So your labor market, the way employment is structured in Kenya is such that most of people who are employed are in the informal sector.
Yeah.
Okay. Now, what it means practically is that their incomes are unpredictable. So we don't know how much people are going to earn. We don't know how much a Nduthi guy is going to earn tomorrow. We don't know how much a Mama Mboga is going to earn next week, and so on and so forth. So they're unpredictable. They are irregular. They might have a windfall this month or this week and have nothing, next week and so on. And they are not collected in a structured way, so you can't tap into them. Okay, so that's a challenge with the informal sector. Now in Kenya, the informal sector is about 83%. So most of our population that are working are in the informal sector. Now, poverty is another thing. In Kenya, the last census, which was, measure of poverty in Kenya was about 2015, right, which told us that about 36% of our population live below the national poverty line. So we are saying the majority of our population are, number one, poor, live below the poverty line, so affordability is an issue, and second, are in the informal sector. We don't know their incomes, we can't track their incomes, it's unpredictable and so on, which means when we ask them to make contributions every month, we are not sure they'll be able to do it. Okay? Now, and that comes with specific challenges for collecting revenues for the health sector. One, what it essentially means is that every month we have to hope that these people are going to make contributions. So what you then end up is a situation where you have what you call attrition. So people fall off. So when someone has a windfall, they contribute, and then when they don't, they're unable to contribute, and so they fall off.
Yeah.
Okay? So what we see in NHIF is a very high attrition rate. We've seen the NHIF going out to mobilize people to register,
to become members.
To become members and so on. Which is, their heart is in the right place. Okay, so go out there, convince people, and people are reasonable. They will register. But then over time, they fall off. we did a study about a year or 2 years ago, following up individuals with hypertension and diabetes over a period of 1 year. Because the assumption was if you register these individuals with the NHIF, then their healthcare needs will be sorted. Okay, NHIF will pay for that. And so got registered at the beginning of the year, followed them over a 12-month period. At the end of the 12 months, 70% had fallen off. Okay? So you have an attrition rate of 70%.
Wow.
And why had they fallen off?
They're falling off because, number one, most of the time they can't afford. Okay? Number two, like we said, their incomes are unpredictable. So they're, this time they have money, the next time they don't have money. And so they are unable to pay, and so on. And then third, because it's voluntary. It's not, these people are not captured automatically. So because it's voluntary, then human nature, when you look at the way human beings behave, is such that they do things when they think there's something in it for them.
Yeah.
Okay? So we have what we, in technical terms, we call it adverse selection, where the people that stick in are the people that need it the most.
Yeah.
And then the people that think they don't need it, don't stick in. So you have a situation where young people, and a lot of the informal sector, you have young people driving motorbikes around and so on. They don't think that.
They don't think they need
it until something happens.
Yeah.
Okay? While you have people that actually need it. So the people that actually need it sometimes get into it. So that is a problem you have. You have people that really, really need it in. You have people that don't need it, think they don't need it out of it, and so it tips the balance. So you have a situation where it becomes unsustainable for the fund to.
But Professor,
hold on, City.
Yes,
let's do that break. Kenya's biggest conversation with Professor Edwine Barasa, who's the Deputy Director at the KEMRI-Wellcome Trust Research Program. We are talking about the economies of health financing, and we're talking about universal health coverage. One of the vehicles, the main vehicle that's been touted by government is NHIF. Is it the most practical way of achieving universal health coverage? That's a question we're asking ourselves this morning, and the researcher is here to help us through it. TT.
This discussion around UHC and whether people who work in the informal sector can afford it is a truly interesting one. Interesting in this sense, these people make a living in this sector. They parent, they have families, they survive with it. So if that's something they can do, yes, with a struggle, but they can do it. The model of asking the individuals to pay is what we're saying doesn't seem to work, meaning you volunteer and you pay. Yet these very same people are in SACCOs. These very same people are in chamas. And in some of these organizations that, again, they volunteer to be in, they work fairly well and they achieve the goals that they set. So perhaps the discussion we ought to consider is the models where these people work in groups which have succeeded. Can we borrow from this to ensure that this very pertinent and very needful healthcare participation and their participation in it follows that model, as opposed to asking the individuals to contribute?
For health.
Yes, because the group helps support each other, and the group is able to fill in blanks where they exist. I'm saying the groups have shown that they're models that they use to better their lives.
What do you think incentivizes people who are in chama, in whatever, table banking, to actually not default in their contributions? There are those that are even contributing on a weekly basis,
yes,
and they don't default.
It's the same principle with SACCOs. How do you get money from a SACCO? People guarantee you. Yes, you have that system that guarantees that, and it's the people who know you, who work with you.
So there's an accountability system.
Yes, there's an accountability factor. So and there are those who argue that it is the same reason why you find a very low default rate in SACCOs and so forth. That very system. I'm simply arguing that there is a system that works for these people in the informal sector, and it helps make their lives better. Has that system been considered with reference to universal healthcare?
Thanks, and I think that's quite an important question that has several dimensions, right? The short answer to that is yes, that has been considered. So if you brought someone from the NHIF here, and ask them whether it's a strategy they use, they'll say yes. In trying to think, because the NHIF is not blind to these challenges. They know that we have to think about how do we capture people from the informal sector. And one of the strategies that the NHIF has attempted to use for a long time is let's try and get them through their organized entities. So, SACCOs and so on. Okay, so it's a strategy that has been tried, and again, it's a step from trying to look for the individual, because what you want is people who are organized or aggregated. So you have an individual, you have a SACCO, you have more people, you can convince the SACCO to make some contributions to the NHIF and so on. And so the NHIF has tried to do that, but again, we are here, right? So what does that say? It tells you that in as much as that strategy has been tried, again, it hasn't worked very well. And I will get to that, right? I'll get to that. One of the sort of tenets, you remember, and you said it, okay? People in the informal sector clearly spend money.
They do.
Okay? So at an individual level, they spend money. So why is it that we are trying to get them to the NHIF? Why can't we let them? I mean, you have money in your pocket, so keep that money. When you fall sick, sort out your healthcare needs. We know that's a problem, right? We know that for a health financing system to work, we need to pool resources.
Yeah.
Now, the ideal for pooling resources is to make sure that the pool is as big as possible. Because the bigger the pool, the lower the sort of average cost. Things become more affordable and equitable and so on. So you have the NHIF, and then you have multiple SACCOs. How many SACCOs do we have in this country? There are several. They are bigger than the individual, but they are way smaller than an insurer. So you're making a step in terms of sorting out the fragmentation at the individual level, but you're still fragmented, right? So it doesn't completely solve the problem. Okay, so it doesn't completely solve the problem.
No, it doesn't.
Okay?
But consider, for instance, the success stories around NHIF have to do with people who are in employment.
Yeah,
and it works because it's deducted from source. It's not as though somebody is asking your opinion about it.
Absolutely,
it is deducted and it is given.
It's automatic contribution.
Yes, it's contribution.
Exactly.
So I am saying it works.
No. You're saying making collecting funds from formal employment
works. That's what I'm saying.
Because of the mandatory nature.
Exactly.
I'm saying
so that works.
Yes,
and
it does.
so NHIF, when you look at the population in terms of formal sector and informal sector, formal sector is 100%, because you and I don't make decisions. Salary checks in a couple of days, NHIF is already gone.
Yeah.
Okay, so very great way of making sure that there's compliance and so on.
Yes.
Okay? The challenge is with the informal sector. You can't make it. It's
the voluntary
difficult.
bit
At
of
the
it.
baseline, the default is not, it's voluntary. The default is not automatic. So you have to think of what are the ways to make it automatic. Now, we can say, well, they make contributions to SACCOs. Okay? So if they make contributions to SACCOs, then let the SACCOs deduct.
Remit on their behalf.
Exactly.
Yes.
And like I said, the NHIF uses that approach already. So it's not a new proposal. It's a proposal that is being
success rate
used.
on those ones?
It doesn't work very well.
Why?
So
because
is it the problem with the SACCOs, is the problem with the NHIF?
It's at all levels. First of all, not all individuals in the informal sector belong to SACCOs. Second, not all SACCOs contribute to the NHIF. And third, SACCOs, like I said, are still fragmented. You still have quite a number of them. What we need to be asking, I think what we are probably struggling with, which is the LGO question, which is how do we collect revenues from these individuals? That's really the important thing, right? How do we collect revenues from these individuals? The idea is to figure out a contribution mechanism that is actually feasible. And we don't need to reinvent the wheel. Well, you can be creative and innovative, but it's also good to look at what others are doing.
What are they doing?
When they've been successful, And when you look, across the continent and in countries that look like ourselves, we have very many countries that have failed in terms of trying to get people to a health insurer, but we have some countries that have actually done well. So you have a country like Rwanda, You have a country like, Ghana. You have a country like Gabon. Outside of Africa, you have a country like Thailand, and so on and so forth. And what these countries have done is to figure out that actually all these people pay taxes in one way or another, because as long as you're spending money, you are paying taxes.
Yeah.
Okay? So taxes are an automatic way of collecting revenues from the population. And so what these countries have done is to use tax funds, to think of innovative ways of using tax funds to fund their health system. Okay? So I will give an example. Nigeria. Sorry, not Nigeria. That's a terrible example. It's a worse.
Ghana.
Right? Ghana. Okay? So Ghana is, coverage in Ghana with health insurance is about 70%. So it's doing very well. Okay?
70% of the population.
Of the population is covered.
Covered in terms of access?
Is enrolled to their national health insurance.
Okay, enrolled.
So 70% of Ghana's population is enrolled, compared to Kenya's, which is about, I think the latest estimate is about 24%. Okay? So we've really struggled at around 20. Ghana is 70% and keeps on going high. Okay? Now, when you look at how their national health insurance fund or scheme is funded, it is almost 90% funded through taxes. And they've thought about this. So, for instance, they've taken, they've earmarked 2.5% of VAT. Okay? Who pays VAT?
Everybody.
Everyone.
Yes.
There's
no escaping VAT.
Everyone. Okay? They've taken 2.5% of VAT and earmarked it. So they've allocated
so it's
automatically.
ring-fenced.
It's ring-fenced for the NHIS. Okay? And then they've taken another 2.5% of their social security contributions. So that's mostly in formal sector, right? It's the equivalent of NSSF.
So the NSSF,
exactly.
Some 2.5%.
2.5% goes to their NHIS, the equivalent of NHIF.
Okay.
And then another 2.5% from their VAT goes to the NHIS. Okay, and then when Parliament sits every year, they make some allocation to the NHS as well. So you have substantial tax funds, and they still collect, from employees, formal employees. They still make their, percentage of their salaries and so on. And what that happens is that then their national health insurance is predominantly tax funded, and it allows them to now start covering poor people. So they identify poor people, they have them in, those guys are given what we call subsidies. So, they don't have to pay. And then the informal sector people, like we said, are paying indirectly through VAT and so on. And they've achieved coverage. Rwanda is even more innovative, and that shows, a very strong sort of willingness by government to support their health insurer, right? So in Rwanda, you have several earmarked taxes. So the government, again, allocates at the beginning of every fiscal year. The government allocates, and then you have a raft of ring fencing, as you put it, raft of ring fencing. So road, this road traffic
development levy.
No, the road traffic fines. So fines, go to the
health.
Go to health. Some amount, sort of registration of medicines, registration of, when you do research, we have to pay something to get approvals and so on. All those revenues, go to the NHIS. Tourism sector. So when you go to Rwanda and you sleep in a hotel and so on, those revenues, a percentage of it, some of it goes to their community-based health insurance. A raft of ring fencing of resources, telecommunications revenues, part of it, fuel, for every liter of fuel you buy in Rwanda, there's a percentage that goes to their social health insurer and so on. In Gabon, 10% of revenues, their telecommunications revenues, go to their national health insurer and so on. So they identify opportunities to earmark tax that then goes to the NHIS. And what that does is mobilize sufficient resources to allow these people that we are trying to cover. So this thing
so what does
is
it
about...
do?
Yeah?
Let's now talk about the impact of that. In Rwanda and Ghana, the examples that you've given.
Yes.
How much do they end up collecting? Is it sufficient to actually cover the entire population? And what does it cover?
Good. So, do they collect a sufficient amount to cover the population. Now, the numbers speak for itself, right? Rwanda is about 90% coverage. So 90% of the population in Rwanda is covered under their social insurance. So they've managed to collect revenues to allow to facilitate that. In Ghana, remember I said universal health coverage is a journey.
Yeah.
Okay.
Yeah.
So in Ghana, 5 years ago, they were at 40%. Now they've moved to about 70%. So the numbers keep going up. So are they able to mobilize resources to provide greater coverage of the population compared to Kenya?
Yes,
the answer is yes. Now, is it enough? The answer is no. Right? Because one, they haven't gotten to 100%. Okay? And second, they're still struggling with the challenges that every other health sector, especially in low and middle income country, struggles with, which is, yes, we've collected these resources, but are these resources sufficient to cover all our healthcare needs? And that's a progressive thing.
Okay.
So on that side, the answer is no, because so the idea is, if these are your healthcare service needs, you need to keep on progressively increasing up to the point where you get to an optimal level. And we haven't. No African country has reached there yet. But you have to make progress on all these dimensions. So and they are clearly making better progress on the financing dimension, which translates to the services dimension. So Rwanda is one of the countries, for instance, that met what we call Millennium Development Goals, the health goals and so on. It's doing very well in terms of coverage and so on.
It's ticking the boxes.
So
let's compare those two people, okay? A Kenyan and a Rwandese.
Yes.
So Kenya, with the current improvements that have been done to the NHIF Act, let's actually take the latest one.
Yes.
Mandatory NHIF contribution.
Okay.
Let's assume we actually achieved that.
Yeah.
All right. So there's this mandatory NHIF contribution, whatever manner it looks like, right?
Yeah.
And we have more and more people now contributing towards NHIF.
Yeah.
And what the bouquet of benefits has been hailed as.
Yes.
You'll go in, you'll be able to cover a lot of your outpatient for all the health facilities, and a lot of inpatient, and then a lot of, for example, the big ones, the cancers and all, it'll cover to a certain extent. Compare that Kenyan and the Rwandese.
Yeah.
What is the Rwandese getting?
So one of the distinct differences between what the Rwandese gets compared to what the Kenyan gets. Remember, one of the things you said is you have to think about how you're spending the money. So the way we call the benefit package, the list of services you're entitled to, right? So the list of healthcare services that a Rwandese is entitled to includes what you call primary healthcare, basic, essential healthcare services. Okay? While in Kenya, most of that list is skewed towards your secondary and tertiary care, so higher level, hospital care and so on. Okay? So that is a distinct difference.
Okay.
Now, what that means is that in Kenya, the NHIF becomes more important to you when you've been admitted, for instance. Now, when do you get admitted? When things are bad. Okay? Kenyans say mapema ndio best. So in Rwanda, because you're sorting out the basic primary healthcare, and preventive and promotive, you're able to catch diseases when they are less advanced before you need to be admitted and so on. And so the cost of healthcare actually becomes a bit lower, because then you're treating conditions that are at an outpatient level. They're still solvable, they're a bit more affordable and so on. So that's a distinct difference between what is happening in Rwanda and what is happening in Kenya. And it does have implications, because then it means if you gave the Rwandese, $1, and you gave the Kenyan health system $1, the Kenyan health system is likely to consume it faster, okay, for a few, for a smaller proportion of the population compared to the Rwandese system. So the Rwandese are able to extract more from that dollar compared to the Kenyan government.
Edwine,
and that is why
go ahead.
In Rwanda you have 90% covered, and in Kenya you have 20% covered.
Are you suggesting that because the healthcare system that we've spoken of in Rwanda takes care of primary healthcare,
yeah,
that approach makes it far more cost efficient than the Kenyan one.
Absolutely.
Why?
Absolutely. Primary healthcare is, the most cost-effective way to achieve universal health coverage, to sort out our population's health needs. Because primary healthcare is basically the basic care that you need, and includes things like, basic curative, but also preventive, promotive. Promotive is not, it's both at an individual level, but at a population level. It's your vaccines, it's, health education, is ensuring that, children are treated with, when they have basic problems and so on and so on. It's really that basic care, it's screening, for non-communicable diseases and so on. And the thing about that is that it prevents diseases from either happening or, occurring or progressing. So it catches them early. Now, that's better than waiting for a disease to develop.
That's an advanced stage.
Exactly. So in Kenya, we catch cancers when they're in stage 3, stage 4.
Yeah.
And they need advanced treatment, and we struggle with where to take them, and then the chances of survival are low and things like that after it has costed a lot of money. While in a system that has strengthened its primary healthcare system, we are able to catch those conditions earlier. We're able to manage them earlier, and we're able to do them cheaply. So it costs much less to see patients at lower healthcare facilities, for instance, dispensaries and health centers, compared to KNH. And
so you're actually saying that universal healthcare can be the vehicle to promoting preventative healthcare.
Absolutely. What you're saying is primary healthcare, which includes, your preventive and promotive and so on, it's a best pathway to achieve universal health coverage. So it's the other way around. Okay? For you, if you really want to get there, then
if
that's
you
your
want to get
best
UHC,
strategy.
you better start at...
You need to start there. That's your best strategy. Why? Because it reaches the most people. Okay? So it's very equitable. Okay. Then secondly, it is also efficient. So you get the greatest bang for the money, which means for $1 that you have, you're able to do way more. But if you focus on, secondary, tertiary care and so on, and focus all your money there, because sometimes, it's sexy to focus on that, to hospitals, big equipment and so on and so forth. The problem is that you have this funny effect where you're neglecting preventive and promotive, and so you're getting more people at that level, and then you're getting overwhelmed.
It's like you're promoting people to get there.
And then you can't afford it. You really can't afford it. You'd rather screen cancers and prevent most of them. You'd rather manage hypertension and diabetes so that they don't get complications and so on, rather than wait until you have stage 3, stage 4 cancer, or complications of diabetes and hypertension, and then build nice, fancy hospitals to sort out that.
To take the people. Prof, even us, we have a layered way of financing our healthcare.
Yeah.
So we have NHIF, contribution, mandatory and voluntary. Then we have tax.
Yeah.
At national level and at county level.
Yeah.
So are you saying we just scrap NHIF and just focus on...
Nope, absolutely not. So we're not saying scrap the NHIF. What we are saying, again, so the task of health financing is about doing 3 things. Collecting resources. So let's find the money, let's collect it.
Yep.
Okay. Let's put it together and put everyone under that. And then let's pay for healthcare services. So what we are talking about is not the NHIF. We are talking about functions, how functions within the NHIF, how is NHIF operationalizing those functions? And we are saying the way it is collecting revenues is problematic. Okay? That's what you're saying.
The pooling aspect is okay. After the money has come...
There are challenges on all those 3. Okay? So we've dwelled on how it is collecting revenues. And you're saying the way it is collecting the funds is problematic. And it needs to reorient that to focus on tax.
Okay.
So if it does that, then that's a step in the right direction. Okay? Then secondly, we need to say, okay, how is it pooling? Okay, how is it pooling? Part of solving the collections is ensuring that formal sector and the poor are in, so your pooling is sorted. But there are issues there you need to sort as well. And then we've talked about what services do you pay for, and we're just talking about secondary care versus primary healthcare. That is about how it is paying for services. So we need to sort out how you're collecting. We need to sort out how you're pooling, and you need to sort out the services
you're paying for.
Yes,
Prof. This has been a very enlightening conversation, and we need you to come back so we can continue, right? Because it's an ongoing debate.
Yeah.
We have universal health coverage as a conversation, and we must realize it.